Hello, welcome to this lecture on human factors in healthcare. It's a slightly unusual topic, but it was a very, very interesting one when I was invited to do it. Not so much a legal lecture, but it was what it said on the tin, really. It was when things go wrong, even when things go right, what is the human element in all of it, and what lessons can we draw from it? And because of my own particular background, I'll come on to that in a minute, I want to talk principally about this idea of profiling repeat offenders. So what I mean by that is looking at medical professionals who have committed multiple offences, if you like, been involved in some high profile group actions, and try and see if we can draw out the human factors and identify any lessons from all of that. And I just want to close on an issue about understanding medical literature, which in a way is aligned, but more than anything is just a bit of a bugbear of mine, and this is a really good place to shoehorn it into. So another way of describing this, subtitling this lecture, would have been to say it was lessons from group litigation. So my career has been principally concerned with dealing with some very major bits of group action, group litigation. First one was Leicester epilepsy litigation. I'm going to come on and talk about all of these. But there was 600 cases or so that I dealt with there. Then Liverpool Women's urogynaecology litigation, which is more recent. I'm going to talk about both of those in some detail, give you some background on that. I'm going to see whether I can construct a psychological profile that crosses over both of those cases that's common between the two consultants, and see whether you agree with me. And then look at some anonymous examples where I think it applies as well. And then see what we end up with, if we've got to work on a model that we can use to go forward. And that's what this is about, really. It's what can we take from the past, apply it to the future, and stop the repetition and the cycle of these cases. So that's what I'm gonna try and do. It's a pretty bold subject, if I do say so, but I think it's very interesting. I hope you will as well. So the Leicester epilepsy litigation, I suspect not many people have heard about it. It started back in 1998, kind of the litigation kicked off, but it goes back a little bit further than that. So concerns, and I should say as well, if I'm talking about facts and naming names, that's because it's all in the public eye. But lots of articles about this. I've written some of them. It's been in the news. There's no confidentiality being broken here. When I anonymize certain things later on, that's because it's not well known. So nobody needs to worry about that. So in Leicester, Dr. Andrew Holton, he was a consultant paediatrician with a special interest in paediatric neurology. Bear that in mind, that's quite interesting. So it's distinct from being a consultant paediatric neurologist. It's a consultant paediatrician with a special interest in paediatric neurology. And you don't see the use of that descriptor too much anymore. You still see it from time to time. It used to be a little more common. It's slightly confusing. I suppose if you were being referred to somebody who was a paediatrician with a special interest in paediatric neurology, you wouldn't necessarily draw a distinction between them and a paediatric neurologist. Well, I'm going to suggest to you that there is a distinction to be drawn. But in any event, that's what he was. He was a single-handed practitioner. Okay, and again, all of these points I picked out for a very specific reason. So what I mean by that is at Leicester Royal Infirmary, he was the only individual practicing in that particular area. So he had no peer review. That's the key point here. What's very interesting about Dr. Holton is he managed to develop, I think partly through force of character, but also generally through the reputation that spread. He had a tertiary referral centre. So he wasn't just dealing with cases in Leicester. People from much wider afield all over England, in fact, were referring complex cases to him. And in particular, he was dealing with children with epilepsy. Now, that was invariably in the context of other underlying neuropsychiatric conditions, neurodevelopmental conditions. So a lot of his patients had autism or ADHD or other more profound genetic syndromes, but with epilepsy super added on top. So a lot of them were very complex cases. And he purported to try and deal with them all. So concerns about his attitude, that's important, were raised in 1995. They were raised by parents and by staff. So he was, he could be quite belligerent. Concerns that people may point at me and say the same thing now, but I ask you to hear me out before you make any accusations. And if people didn't do things his way, he was known to confront them in corridors, and he would shout at them, including patients. And it really was very much his way or the highway. And what he had about him that set his practice apart, and not in a good way, was what I've described here as previously unrecognized polypharmacy. I think it's still unrecognized. So what I mean by polypharmacy is the use of multiple medications all prescribed at the same time. So for very, very difficult epilepsy, you might prescribe 2 anticonvulsants at the same time. You might go to 3. You don't really go past that. And to get to that point, you'll have gone through a trial of different medications. So you might try carbamazepine in different doses, and that hasn't worked, so you'll switch it out and you'll try lamotrigine. And maybe that hasn't worked, so you'll try vigabatrin or one of the other medications, and there's lots. And then you might go into combination. And it's a process. And the reason that you do it so carefully is because even individually, these medications have a significant side effect profile. And bear in mind, we're talking about children. So by definition, we're talking about unlicensed use of these medications. And that's okay. They have to be unlicensed because you can't test on children. But nonetheless, the more drugs you start adding in, the more likely you are to see side effects, and potentially significant side effects. But this is what he did. And forget 2 and 3. There were cases when he got to 5 and 6 anti-epileptics, all prescribed concurrently. And I say it's unrecognized because it is not a treatment modality that's recognized by any pediatric neurologist in the world. It was his thing. It has to be said that the side effects seen by some of the children were really, really staggeringly profound. So that was one major area of his practice which set him aside from the practice of his peers. And there was another. If you are suspected to have epilepsy, it is likely you will go for an EEG study, which measures brainwave patterns. Some people, it may not show any brainwaves at all, but in some people, it will show an epileptiform pattern. He chronically misinterpreted EEGs. Almost pathologically misinterpreted them. One formed the impression that it wasn't just that he didn't understand what he was looking at, but that he had such a confirmation bias because he knew somehow that it was epilepsy, that whatever was there, he found a way to say it was epileptic. And I would sit there with pediatric neurologists, and they would look at the scans that he saw, and they would just say, this is ridiculous. There's nothing about this that's epileptic. But he always found a way. Pathologically misinterpreted them over and over again. So there's 2 major defects in his kind of technical abilities, if you like. It's the way he approached polypharmacy and his interpretation of EEGs. And then what happened was, in 2001, maybe in 2000, a pediatric neurologist called Sonny Phillip, that I think some of you will know, was brought in to help Dr. Holton because he was complaining that his tertiary referral services practice was now so huge he couldn't do it by himself. Sonny Phillip came in, and I think he looked at the cases and quite quickly he panicked and went, I don't understand what's happening here. This is not anything that I recognize. And he blew the whistle. And I think, huge respect to Sonny Phillip. I think it was very difficult for him. I don't think he doesn't practice in this country anymore, actually. I think he's gone abroad, I forget where. And I don't know to what extent this played a part in that, but I know it was a hugely difficult time for him. And then what we saw is 618 children bringing claims. That's just such a huge amount. And that wasn't, by any stretch of the imagination, all of the children he treated. What we struggled with in Leicester, or at least what it was suggested we struggled with, was a real cultural issue, particularly with a very significant Indian population who, for cultural reasons, did not feel able to bring claims against doctors at all. That certainly represented, and we reached out to that community to try and engage with them. But I think it was always felt, even to this day, that they didn't bring the claims they could have done. But nonetheless, 680 claims. Last point, counterintuitively, but importantly, there were dozens of families that wrote and said, Dr. Holton saved my child and made a huge difference. And he undoubtedly did. And he undoubtedly was a very caring guy who didn't have any malice towards any of his patients. He wasn't one of these terrible doctors that you see that's inflicting pain deliberately on people. He really thought he was helping these children. He did, and he did help a lot of children. So we can't lose sight of that. So those are the points I want to draw out about Andrew Holton. And then I'm going to come on now to Dr. George Rowland. I'm going to go through the same process, tell you a little bit about the background. As I go through, you'll see, I think, and I will try and draw out points and the similarities and the parallels might start to jump out at you, just like they jumped out at me. So this is now a little bit more present day, kind of early 2000s. And Dr. George Rowland was a consultant gynecologist with a special interest in urogynaecology. I don't need to make that point, it's bond or obvious, isn't it? Once again, we have a more generalized practitioner, but with this special interest in, and one wonders what protections there are, what requirements, what regulatory obligations there are before you can start saying that about yourself. Interesting topic, not for now. But that was his special interest. Well, what else? Well, he worked as a single-handed practitioner for a very long time. Part of that problem was because there were two trusts in Liverpool offering women's services that amalgamated, but he remained off-site, away from the main body of women's services, if you like. And there was an organizational, structural, managerial separation, which was quite unfortunate. But he was ostensibly a single-handed practitioner, not just for that reason, but also because he was the guy that was doing the urogynaecology work. You'll see the parallels. They're so obvious. I don't need to explain them. Dr. Rowland chronically misinterpreted investigations. So if a woman presents with incontinence, there's typically two causes. So there's stress incontinence and there's urge incontinence. And there are tests you can do which will demonstrate which is which. And this is absolutely fundamental, because stress incontinence you can treat surgically very well, very effectively, curatively, transformatively. You can make a huge difference. Urge incontinence you cannot correct surgically. It's not surgical, there's no surgical target. It's worse than that. If you perform surgery on a woman with urgent continence, you are very likely to make it worse. And one is inclined to say that Mr. Rowland either didn't believe that you couldn't cure urgent continence with surgery, or he just really, really liked operating. I don't know what the reality of that was. But he would always find a way to diagnose stress incontinence. So he had a surgical target and he would operate. And he operated on many women with urgent continence and made many of them worse. He was also known for bundling procedures. He, again, a bit like the polypharmacy, what you would do is you would undertake one operation at a time. So you might do a sling, so there's a TOT procedure, a TVT procedure, a colpo suspension, a sacrocolpopexy. There's lots of different potential operations you can do. But you pick one, you do that operation. If it works, fantastic. If it doesn't, then you might want to do something else. He would find a justification for doing what's called bundling and doing 2 or 3 procedures all at the same time. So that manifestly increases the complication rate, the risk of it just not working. It makes it a much more technically difficult operation, so it means you're more likely to make a mistake. Increases recovery periods, so everything about it is just wrong. Nobody does that. That's not something that you do. So in 2004, concerns were raised. If I remember correctly, he actually had gone on holiday and his clinical director, I think it was the medical director at the time as well, was looking after his cases and noticed the problem. But note the difference in the dates here. It wasn't until 2007 that the investigation was started. And it wasn't until 2008 that he was suspended. So that looks problematic. He was noted to have an attitude problem as well. And again, he was noted to be abrupt to staff and to patients. And it was exactly the same thing that I described before with Andrew Holton. So if people indicated they didn't want to follow his treatment recommendation or asked for a second opinion or in any way queried what he was doing, he would react in a very volatile way. And he would do that particularly to the nursing staff as well. So even though there were 400 claims, there were many letters of support received from women who said that he had genuinely helped them and made them better. So even though before I said, well, he seemed to have this predilection for surgery, maybe it was a genuine desire to try and help people, but because he did seem to be a genuine person. So yeah. So that's the background to those two very, very significant high-profile group actions. I even to this day, the number of cases in the Leicester epilepsy litigation makes it one of, if not the biggest, group action that there's been. So this slide here is my psychological profiling. I'm being a bit grandiose, but you all know what I mean. So we picked them up as we went along, but let's just be explicit. So both of them were working in isolation. And what's significant about it is there's no peer review. So in any profession, whether we're working here in a law, whether we're in a medical setting, we rely on our peers to correct us for something straight and narrow, or just for the ability to talk to people and just say, hey, I'm not quite sure about this. This is what I think of doing. What do you think? And that's such a fundamental part of the professional experience. And neither of them had that. Complete echo chamber. All they heard was their own opinion, just echoing around in their own heads forever. Both of them, I think it's fair to say, were pushing into an area which is quasi-experimental. You could say just outside the norm, but they were both pushing boundaries. So Andrew Holton must have known that he was going outside the scope of professional, of common professional practice when he was adopting polypharmacy. Mr. Rowland must have known that nobody else was bundling procedures like this. I think they both must have felt that they were pushing the envelope. They were, exploring, new ways of providing treatment. It's very interesting to me that they both had these attitude problems that seem to be quite profound. I'll come back to that in a minute. And they both had very clear areas of technical deficiency. You can really, it's not just in the generality that they had bad outcomes, is they very specifically were deficient in the interpretation of investigations or their approach towards certain key activities. And they genuinely helped a lot of patients. I put that in because it's important. It's a real factor. And I think I've alluded to why I think it's important. I think it would be wrong to characterize either of these people as being malevolent. I don't think that. I think they were very misguided and they were wrong. But I don't think there was any malice there. And I think that is relevant. They weren't trying to hide what they were doing. It was done in plain sight. It's also very important. They were both allowed to practice long after first concerns were identified. And I put this in square brackets, it's the last bullet point on the slide. It's less part of my commentary on the profiling of these people, but it's a huge lesson for corporate structures. It's not just in the medical profession, you see it in the legal profession, you see it everywhere. You see it in the teaching profession, you see it in emergency services. We've got big problems in London right now because somebody who was known to be involved in a pattern of inappropriate behavior was just allowed to continue. And it's the same for both of these people. Okay, well, maybe I've just got lucky and found two cases where they join up. To try and test that, we've got to take my psychological profile and see whether it works if we look at another group action. So let's do exactly that. So Ian Patterson is quite a infamous, I think it is more appropriate to say, group litigation in the Midlands. So he was a consultant breast surgeon. I certainly knew him. Some of you may have known him as well. He did a lot of medical legal work, was extremely well respected, really at the top of his profession. Now, he pioneered something called cleavage-sparing mastectomy, which was, not only was it unapproved, it actually was in direct contravention of national guidance. And effectively, it's in the title really, but he would not remove all breast tissue when he was doing these operations. And that would assist him in the cosmetic results. And he'd come up with this. You could immediately, kind of work through why that might be problematic in treating someone with breast cancer, but that's what he did. So think back to what I said about Holton, what I said about Rowland, both pushing the boundaries, expanding on what would be the ordinary course of treatment. That's what he was doing here, invented something. Attitude, again, was a really major problem with Patterson, and lots of the patients in particular, but also the staff, when they were eventually able to give their opinions, said that he really was a problematic character. And there's just one quote there, said he acted like a god. He knew best. He'd come up with this fantastic operation. It was the one you needed to have. He could save you. He could give you a good cosmetic outcome. Nobody else could. He was the guy. Blimey, look at the last bullet point. First concerns raised in 2003, not suspended until 2011. You see it so often. But again, okay, not every aspect of the profile, but look how many similarities there are there. The attitude problem, so closely tied into the idea of doing something that's outside of the ordinary. And of course, because he was doing this operation that he pioneered, that nobody else was doing, he made himself a single-handed practitioner. He came up with the operation, he did the operation, nobody else was doing the operation. Okay, he didn't feel he needed to speak to anybody else about it, but there was nobody to question him or correct him. It was his little thing. So isolated, pushing the bounds of medicine, acting with a really poor attitude. I think the profile fits. Slightly more circumspect with this one. I'm not going to name the doctor, it's just going to be MN. The doctor was a surgeon in a particular area and did a course on laparoscopic surgery, and he set himself up as the sole practitioner at the trust, the sole surgeon who could do laparoscopic surgery for this particular condition. It was just him, single-handed practitioner, no peer review. By the way, you'd be surprised how little experience you need in laparoscopic surgery to be able to set yourself up as a laparoscopic surgeon. I'm not saying I could do it, but I'm not, it's not that many hours worth of training. And his technical deficiency was sadly in laparoscopic operations. He was just very bad at them, quite frankly, and there's no other way to express it. So when he was removing a particular organ that ought to have been removed in one specimen piece, because this was a cancer operation, he would chop it up into pieces. There's no other way of describing it. This specimen, rather than being removed whole, would be removed in pieces. And of course, if you're dividing through a structure that's riddled with cancer, it raises the real risk that you're disseminating cancer through the patients. That's exactly the problem. He was just a bad laparoscopic surgeon, but there's nobody else doing it, so who's to pick it up? No direct evidence about his attitude, except this. He was a minor television celebrity. We quite like that. He'd sorted out because of his specialty, and he'd made himself into that. And I can't help thinking that it's fair. I think about Patterson thought he was a god, and he'd invented this new operation, and and this guy had gone out and he was on TV, and he was, it's quite similar. It's similar enough for me to put it to you that the profile templates over him quite well too. So if you're with me, we've got a template, and we've proven it with reference to 2 more cases. So what? Yeah? What have I achieved in my last however many minutes? Well, profiling is dangerous. You usually hear about it in terms of racial profiling and people getting pulled out of lines at airports and so on and so forth. That applies to all kinds of profiling. There's another really important truth. It works to some extent. That's why people do it. There's all manner of inadvertent consequences, but it does work to some extent. So the question is, what can we do potentially with the profiles that I've identified? And there are definitely a couple of things. I've given this lecture quite a few times now, and I guess these are for medical practitioners, particularly those in the corporate structure, in management, these last 2 bullet points are the real take-home points for them. So, they're the take-home points for you as well. Stop single-handed practitioners. Just don't have it. Do not have a single person who is responsible solely and entirely for dealing with a particular kind of treatment or a particular patient. It's proven over and over and over again to be a fast way of getting to some very bad places. If you have to have, for resource reasons, for example, if you have to have just one person doing that operation in a hospital or looking after, children with epilepsy in a hospital. Arrange peer review with other hospitals, with other units. It's entirely possible to do. It's fantastic practice. It should happen, just as a matter of course outside of this lecture, but do that. And there should in the UK be nobody who is a single-handed practitioner in any field that doesn't have that kind of peer review taking place. And then take complaints about attitude seriously, because it may mean nothing at all apart from the fact somebody's got a bad attitude. But it very often highlights something that is underlying and is much more profound. It may be somebody is overworked and therefore they're cutting corners, or they're not reading investigation results properly, or any number of different things. It might be that they do not respect their colleagues, that they do not respect their patients, because they have come to a place in their career, in their practice, where they feel that they are beyond the commentary of their peers or indeed of anybody else. And in all of the cases, except the last one, but with Patterson, with Rowland, with Holton, for years and years and years, there were people raising issues about attitude. And in every single case, had they been pursued thoroughly, just think of how many cases might not have come about. Okay, so that is the main part of the lecture completed. I just want to do a couple of minutes on a bugbear of mine. I've got a captive audience, so I'm gonna do it, and it's this: risk of adverse outcomes in the literature. I don't remember what he was supposed to denote. I think it was that people had already sat through quite a long lecture and were cross that I was now giving them this as well on top, but that's tough. It's all about statistics and understanding risk. Okay. In a laparoscopic cholecystectomy, what does the risk of damage to the cystic duct actually mean? Okay. So there's a case study that's listed there. 114,000, 5 cases, 0.5% occurrence of major bile duct injuries. What does that mean? Does that mean, and some people will tell you this, that there's an unavoidable 0.5% risk of a major bile duct injury whenever a laparoscopic operation is performed? The recommendation, and that's certainly how that's interpreted, but if you read the reports, the recommendations for lateral retraction of the gallbladder neck and careful dissection of K-Lott's triangle, does that not mean, okay, that in 0.5% of cases there was inadequate retraction of the gallbladder neck and less than adequate careful dissection? That's exactly what that means, surely. So what I'm saying to you, and it apply, and laparoscopic cholecystectomy is just where I see this time and time again, but it applies to so much else. When somebody tells you there's a recognized risk of a particular outcome, you need to ask themselves, say to yourself, is that not just the literature recording the number of times the surgeon gets it wrong? Because if it's not that, what is the explanation for the deviation from a normal? Because you should be able to look at those 0.5% of cases and say, well, this is what was different about them. The cystic duct was in an unusual place. K-Lott's triangle was actually a sphere or a rectangle or something, I don't know. You can't just say, oh, in 0.5% of cases it goes wrong, and therefore for the rest of the time in 0.5% of cases it will go wrong. But that is locked into the minds of surgeons. This is said to me constantly, oh, the literature says there's a recognized risk. Well, we need to think about that. And we've done a completely separate lecture on informed consent, and we certainly won't go through it now. But here's my last bullet point. If we were all surgeons and we had to consent patients to the risk of human factors, so to the risk of somebody just getting it wrong, or of the surgeon being off on a frolic of his own. How would you quantify that risk? And how on earth would they react? How would they react? What would they say? Really, this is all about eliminating the human factor from medicine, and getting to a place where wherever you go, whoever you see for your treatment, you get a standard of care that is at a level that we are all entitled to expect. Okay. So that's just a few words on interpreting medical literature. Thank you very much.